Good morning, good afternoon, good evening. I'd like to welcome you to the WFH VWD session virtual summit entitled WFH Global Initiative for Better Care of von Willebrand Disease. This is indeed a timely topic given the novel findings in the pathogenesis of von Willebrand disease, the many patients for whom we care where current treatment fails, and the new WFH, ASH, ISTH, VWD guidelines, which will be presented later at this meeting. We have three outstanding speakers, each of whom will speak for 20 minutes, followed by a 10-minute Q&A. So please join me in welcoming Dr. Augusto Federici, a professor of hematology from the University of Milan, who will discuss VWD outreach and diagnosis, Dr. Roshni Kulkarni, a professor of pediatric hematology from the Michigan State University in East Lansing, Michigan, USA, who will discuss VWD management and therapeutics. And finally, Dr. Rezan Abdul-Kadir, a consultant in obstetrics and gynecology from the Royal Free Hospital, London, England, who will discuss management of women with von Willebrand disease. So without further ado, we'll have Dr. Federici start the first talk. Dr. Federici.
Okay, next slide. This is a mild modification, minor modification of the original classification proposed by Evan Sadler, where we have a quantitative deficiency.
Go ahead.
This is my first slide, the title, then I have my disclosure, and then I have my first slide called this slide is von Willebrand disease caused by quantitative or qualitative von Willebrand factor defects. Von Willebrand factor is not a coagulation protein, but is adhesive glycoprotein, playing a major role in primary hemostasis. As you can see in this cartoon, the von Willebrand factor play the interaction between platelets adhesion to the subendothelium and a platelet interaction on the vessel wall. Next slide, please. So we have the classification of von Willebrand disease, partially modified from the original one by Sadler, where we have a classification of quantitative or qualitative deficiency of von Willebrand factor. The quantitative deficiency is mainly due by type 1, is present in type 1 and type 3, where the type 3 is the most severe form, where the von Willebrand factor is almost absent. In the qualitative deficiency, there is the von Willebrand factor is dysfunctional, and according to the level of dysfunction and to the site of the dysfunction, we have a type 2A, type 2B, type 2M, and type 2M. Next slide. One of the major problems we have in von Willebrand disease, understanding is that there are definitions that very important to be discussed. The definition as the most common inherited bleeding disorder of von Willebrand disease really actually derives from a few ad hoc epidemiologic investigations. However, in the clinical practice, most of these individuals present with mild bleeding symptoms and do not need specific therapies. So, in other words, there is discrepancy between epidemiological data and real-life data because von Willebrand disease patients, regular follow-up at the Hemophilia Center because of bleeding problems have a prevalence of 0.1 to 0.01% of population. So, probably less than hemophilia severe in our general population. Next slide. Another important current issue that we have to face in 2020 is that, differently from hemophilia A, easily classified severe, moderate, and mild by baseline factor VIII level, clinical severity of different VWD forms is not well established within types so far. And in order to have a correct and confirmed VWD diagnosis, we need to, every patient should meet the three main criteria: bleeding history, low von Willebrand factor activity, and inheritance. And another important aspect, issue that should be discussed today is that bleeding symptoms observed in VWD most of the time overlap those usually observed in normal individuals. So we need a specific detailed bleeding assessment tool to distinguish what is really happening in these bleeding patients versus normal control with some bleeding. The real aspect, next slide, see in this slide where the evolution of value of bleeding assessment tool is reported by Paula James, a co-worker, it's really clear that these kind of symptoms that can be present in von Willebrand disease sometimes overlap in a normal population. For instance, we want to see postpartum bleeding. If you consider the normal versus type 1, actually there is a wide range of frequency of this kind of symptoms. Therefore, what we need to always take into our consideration is the fact that the three criteria, bleeding history, low von Willebrand factor activity, and inheritance, must be always met. And this is an example in the left part of the slide. The symptoms are discussed with a score from -1 to 4, and this was used in the European study with von Willebrand disease type 1. On the other hand, on the other part of the slides, on the right part, we want to emphasize the major important role of the platelet interaction and the von Willebrand factor subendothelial interaction measured by collagen, and because these are the two major clinical laboratory activity we should assess. Last but not least, the autosomal dominant is present of von Willebrand disease in most of the cases. Next slide. So, of course, the most important, another important aspect I would like to discuss today is that due to the multifunctional role of von Willebrand factor, correct laboratory diagnosis, of course, is a little more complex and do require a panel of expensive tests not always available in many centers. On the other hand, the correct clinical laboratory diagnosis is essential to identify mild von Willebrand disease who need only supportive therapy, probably the AVP, or moderate versus moderate severe cases who require von Willebrand factor concentrates. And this expert panel has the role to improve awareness of VWD by proposing a simplified diagnostic approach. Because, next slide, we have, if we want to assess specifically, we need to propose more than 10 tests as we did in the past, a basic test, a specific test, and second level test. I emphasize in red what I believe are the most important, and in the next few slides I will try to demonstrate you that next slide, the classification of VWD based at least on 7 tests we certainly can be simplified because all these tests are not always needed. Next slide. But in order to understand what is really needed for vulvar disease assessment, we needed to go back to the reason why the patients of vulvar disease do bleed. And this is a very simplified system because we have a vulvar factor into the circulation that goes to the collagen on one side and to the platelet to the other side. And then we have also the possibility that the vulvar factor goes interact with as a complex with the factor VIII. So we needed to understand, to assess at least three activities of the vulvar factor. Collagen binding. Next slide is summarize the role of collagen binding. I don't have to go into detail, but what is really important for me to discuss about collagen binding today is that really is dependent on the vulvar factor multimeric size. And using the collagen binding together with the platelets vulvar factor activity related activity is important because this assay can be considered surrogate of for the surrogate measure for the presence of high molecular weight multiples. Next slides, I don't need to go into details, so we can move to the next slide. Talking about the new classification and nomenclature about the platelet-dependent vulvar factor activity. As you can see, there are several aspects, and we don't use, in most of the countries now, we don't use anymore the original ristocytical factor activity. Especially because we have automatic tests like those in the last line, where we call all assays that are based on the binding of a monoclonal antibodies to a vulvar factor in one domain epitope. And next slide, this assay can be automated and they can be performed also in routine lab. They can use immunoturbimetric system or chemiluminescence system. So this kind of assays can be useful also for the assessment very quickly of the platelet-derived vulvar factor activity. Next slide. But before going into details and try to convince you that probably we don't need such a large amount of assay to assess, we needed to go back to the general observations that it reminds us that according to the cohort study that we perform in Italy, we are very clearly aware that there is still a problem to distinguish bleeder versus non-bleeder. On the left part of this slide, you can see that in red, it's very easy to make diagnosis when you have a level of activity below 10 or 20. And you can still have, so these are the severe forms. And on the other hand, we are also able to distinguish patients from normal control with low vulvar factor activity where we have the green zone. But when we come to the yellow zone, this is not really the case. And if you go to the other side of the slide where you have the data we reported in the paper of Blood in 2014, you can also find that if we consider the different types, 1, 2A, 2B, 2M, and 2-3, inside each type, we certainly have different level of activities. So, in other words, we can distinguish severe, more severe, more mild forms without a specific type of vulvar disease. So, in other words, my discussion today with all of you is that we probably should pay more attention to the level, to the type, in terms to have a good management of our patient. And this comes, next slide, and this comes with a very important evidence-based method we assessed during that study in the cohort of Italian patients. As you can see, since we discussed about the bleeding score, and activity, level of activity, like in that case, we measure rhesus factor. You see that there is a very inverse correlation between bleeding score that is can be assessed by bleeding assessment tool and the level, as you can clearly understand that when we have more than 30% of rhesus factor activity, the bleeding score is completely normal. When we go below 30%, the relationship is in inverse. So we have more bleeding score when the rhesus factor activity is very low. On the other part of the Cox proportion Hazard model, this is another very important observation we made in Italy, discussing that when we have a large amount of, larger value of bleeding score, the rate of the incidence of bleeding is very high. And it goes on the other opposite side, when we have a very low level of rhesus factor and the factor VIII that can be used as a surrogate marker in patients with von Willebrand disease where the activity is pretty null. You see that below 20% of factor VIII in type 3, we have very increased incidence of bleeding. Another important aspect that we forget about is that we have the possibility to assess storage of von Willebrand factor and sort of potential endogenous response to the defect by using infusion trial with the DAVP. We have an old experience in the United States, in Italy, in many other countries. And so when we have patients with a very, quantitative effect like Taiwan, you see that we have, this is the next slide, of course, when we have this, we have certainly a very good response, and you see very well that there is the normalization of all the activity on the antigen. And something on the other side of the slide, you see that in type 1 also we have some good response on the activity and of von Willebrand factor. But when we have abnormal von Willebrand factor, like in von Willebrand disease type 2A, you see that there is no correction of the activity, and the multimeric in this side are completely abnormal, even though we have an increased level of von Willebrand factor antigen. Next slide. In the next few slides, I would like to share with you one recent experience. We hope to publish pretty soon, and I hope to submit the journal to the official journal, the World Federation of Hemophilia, because I think it's important for the people attending and working on managing patients with von Willebrand disease. And so this was a cross-sectional study with automatic von Willebrand test this was organized between two centers, the center in Suzu and the center, my center in Milano, with the purpose to evaluate the most rapid simplified approach to VWD diagnosis. Chinese and Italian healthy individuals are also used to have normal controls. Next slide. The three main von Willebrand factor activity, rhesus factor like, von Willebrand factor collagen binding, von Willebrand factor antigen were measured in citrated plasma by ACL acoustic automatic systems using commercially available reagents. The data of the three tests were expressed versus international standard international units, and their sensitivity and reproducibility calculated. These tests were repeated before in 1, 2, 4 hours after an infusion trial with the DAVP. And of course, we apply the rules of von Willebrand factor, try to assess, calculate the ratio between rhesus factor antigen, collagen binding antigen, to make sure to distinguish between type 1 and other, types of von Willebrand disease, especially before and after the DAVP infusion trial. Next. So, in other words, our flow chart was performed in the simplified diagnosis, was something like this. You can see that we did not perform the second level test, but we include the von Willebrand factor activity assessed after the DAVP. The steps were these, and of course, we first perform a blind exercise in lyophilized sample to make sure that the assays were okay, and then we have assessed the von Willebrand disease patients in China and Italy. I have to say that all these tests were performed blindly. Next slide. These are the results. In two blind exercises, both labs in Milano and Suzhou could confirm diagnosis of normal controls, or VWD 2A, type 2B, and type 2M, and lyophilized sample obtained from the standard plasma sample. So we had the possibility to make sure that these assays were very good, and the sensitivity of this assay, antigen, histocytic factor, and collagen binding, were pretty good, with a coefficient of variation below 10%. Next slide. As a result, you see that according to the blood groups, non-all groups, we made also the study according to the blood group in the normal population. Next slide. But the most important aspects I would like to share with you is that we could assess, according to the antigen, histocytic factor, and by calculating the ratio, type 3, number 14, type 2, 1, 39, type 2A, 21, and type 2M. And these were done mainly by baseline level, because the baseline level was sufficient. Then what we did, we performed assay of the DDAVP trial. As you can see, we have a type 1 and a patient with type 1, with a short half-life. And you see that the platelets, we introduced the platelets, and the platelets did not change in this kind of von Willebrand disease type. And you see that there was a correction, very nice correction of the activity and also of the factor VIII. On the other hand, the type 1C, the correction was only very short, and after 2 hours, the patients were just almost at the baseline level. What about the type 2A? We have, of course, correction of the antigen, the factor VIII, but no correction of the collagen and of the histocytic factor. On the other hand, in type 2M, this slide, we have patients with no correction of histocytic factor, but we have some correction of collagen binding and of antigen and the factor VIII, without any difference in platelet count. Next slide. In type 2B, the peculiar abnormality was the reduction of the von Willebrand factor of the platelet content after 1 hour, because we know that there is an interaction, and there was a correction of the factor VIII, while the histocytic factor and collagen binding were not satisfactory. On the other hand, the von Willebrand disease type 1, you see there was correction of the von Willebrand factor, no platelet changes, and no sufficient correction of the factor VIII, because the abnormality of the von Willebrand factor VIII binding. Next slide. So, in other words, with the values before and after the DVP, we could also distinguish, identify, and confirm diagnosis of von Willebrand disease 1C, type 2B, type 2N, and also, I didn't have time to discuss, but also some acquired von Willebrand syndrome. Next slide. So, the conclusion, what we learned about this experience is that the rapid and simplified diagnostic approach with commercial available tests performed also before and after the AVP can be very useful to classify and manage VWD patient worldwide. These results support the use of such an automatic diagnosis in laboratory worldwide, because they can increase the potency of classification in both developed and developing countries. Last slide. Bleeding history collected with semi-quantitative, next slide, okay, semi-quantitative methods as those of BAT and specific automatic lab tests for von Willebrand factor activity should be always used together to identify VWD patient with bleeding phenotype. This specific automatic lab test should be available in most laboratories worldwide, and the DLP trial used to diagnose can immediately distinguish mild patient who can be treated with this drug from moderate severe VWD who must use always von Willebrand factor concentrate. This is my acknowledgement, and I thank you for your attention. Thank you very much. Can you hear me?
This is Roshni Kulkarni, and I'm going to talk on von Willebrand disease management and therapeutics. I'm not sure whether people can hear me or not, but well, these are my disclosures. And von Willebrand's disease, especially in women, has been a topic of an interest of mine, and so I'm really happy to present this. So before we go into anything, I think there is such a tremendous advance in the management and treatment of patients with hemophilia, and I think we are now noticing the advances in management of diagnosis of patients with von Willebrand's disease. And I think treatment is catching up, prophylaxis is catching up, and I'm delighted that the new guidelines that are coming up are going to address a number of these issues. But the general principles of management remain the same, and it includes prevention and treatment of bleeding by knowing the diagnosis, the type of von Willebrand's disease, the bleeding risks, and all that. And Dr. Federici really did a beautiful presentation on all the diagnosis, the methods, the response to DDAVP, et cetera, et cetera. And I think we need to know when to seek medical attention. You also need to know the type of product, the products available, and what to do in terms of elective surgery versus a bleeding episode, and the use of products in special populations and special situations. All of this basically requires a close communication, not only with the surgeon, the obstetrician, gynecologist, anesthesiologist, hematologist, the multidisciplinary, but most important of all, the patient. So just to give you an idea, so these are the products used are your non-replacement products. I'll go into this a little bit more detail. Replacement products and adjunctive therapies, which most of you know, and the situations. So there are situations of surgery, major or minor surgery, and bleeding episodes, major or minor bleeding episodes. As I said, special consideration should be given to gynecologic and obstetric bleeding, gastrointestinal, and joint bleeding. But I think what we are emphasizing now is that prophylaxis should not be withheld from these patients and should be basically afforded to patients who have chronic recurrent bleeding that interferes with their quality of life. So what are some of the products used in the treatment? So we just heard about the desmopressin or DDAVP that increases endogenous von Willebrand factor. Then you have your replacement product, and we all know about the plasma-derived von Willebrand factor concentrate. And we are delighted that currently we have a recombinant von Willebrand factor concentrate, although it is for use in older patients. But don't forget, about 15 to 20% of the von Willebrand factor resides in the platelet. And this platelet associated von Willebrand factor is resistant to degradation by ADAMTS13. And so in some situations, platelet transfusions are indicated, especially in platelet type or type 3 von Willebrand's disease. In many resource poor countries, sometimes these products may not be available, and one may have to use fresh frozen plasma or cryoprecipitate, etc., to save the life of a person. So it is better to treat a person than to say, sorry, I don't have a product, I can't treat it. Now, you all know about adjunctive therapy that promote clot stability, and these include antifibrinolytics and topical hemostatic agents. And I wish I could remove my picture from there. And that includes hormonal and anti-angiogenic factors. So something is missing here. And what is missing? Well, we hear about the non-factor products in hemophilia. Is there a role for non-factor products? Of course, I think recently Dr. Angela Wayne and Steve Pipe and his group from U of M used emicizumab in a 7-year-old boy with von Willebrand's disease type 3 and inhibitors. And they tried everything, and this poor boy was bleeding, and they tried APCCs and recombinant 7A and all. Finally, they ended up using emicizumab, and because these patients have very low levels of factor VIII, and sure enough, they were able to at least take care of his bleeding episode. Can it be used in other von Willebrand patients? I think we need more research and a study into the use of the non-factor product. But at least that was I would say, a window that we got a glimpse of. So let's look at some of these products. So desmopressin releases endogenous von Willebrand factor. And then a trial should be performed. So it's called a DDAVP trial. Most institutions do that. But you have to do a pre-1 hour and a 4-hour post-infusion to determine the pattern of clearance. Because if you're going to use it, then you need to know that the effect lasts for some time till there is hemostasis that makes the patient safe. A response is defined as an increase of at least baseline levels of factor as a toothpaste in a tube of endothelial cell. You can only squeeze it so much. And the majority of type 1 respond. And as you heard Dr. Federici say that there's variable response in type 2A and all that. And it's really contraindicated in type 2B because of increased platelet binding and risk of thrombocytopenia. And in type 3 von Willebrand's disease, of course, there will be no response. The cautions one has to use is, remember, tachyphylaxis, that means lack of response after repeated use, and hyponatremia. It's for that reason that we do not use it in children below 2 years of age. And one has to remember the side effects, hypertension, hypotension. And I remember giving it to a woman, and right in front of me, she had facial flushing, and then she almost collapsed. And you have to remember to limit fluid intake. And it should be avoided in older patients, especially who are at risk for cardiovascular or thrombosis. So, what about plasma derived concentrates? We have a bunch of plasma derived concentrate. They're very safe, they are pathogen virally inactivated, and they have variable levels of factor 8 and ristocetin cofactor. So you can choose which one you want. You want a higher level of 8, you can choose some product. And if you want a 1:1, you can choose some product. It's a great slide from Dr. Sidonio from one of his talks, which shows the different products and the different level or ratio of ristocetin cofactor and factor 8C. It's administered intravenously, and it is good for all ages, children as well as adults. The recombinant von Willebrand factor, on the other hand, is derived from a Chinese hamster ovary cell line genetically engineered to co-express von Willebrand factor and factor 8 genes. So it's a pure product and doesn't contain factor 8 or plasma atom TS13. As a result, it has this full multimeric profile. Now think of the atom TS13 as a scissors. It snips one Willebrand factor into little multimers. And if you don't have that, you have the high levels of the high molecular weight multimers, which is the glue. And that's what you need sometimes. And the interesting thing is it can be used in clinical situations such as postoperative period for continuous prophylaxis. In the USA, it is approved for adults over 18 years of age. Moreover, it has a half-life of 22 hours compared to 12 to 16 hours for plasma-derived von Willebrand factor. So there are other agents such as antifibrinolytics, especially aminocaproic acid and tranexamic acid. At this point, I just want to pause and say something about tranexamic acid. Tranexamic acid was discovered by a Japanese researcher, Dr. Okamoto, and her whole reason for working as a researcher was to find a drug that would help women who had postpartum hemorrhage. She was really never recognized. There was no Me Too movement. When she went to present at a research meeting, people thought she was coming to dance. And she used to take her baby to her research lab so as to work. Her husband was also a researcher. Our very own Dr. Nishida from Osaka, Japan, worked with her and her husband. So I would say, I would like to dedicate my talk to her. We need to recognize these women. There's a beautiful article in Lancet about Dr. Okamoto. So please know the history of tranexamic acid. The woman trial has really proved that it reduces mortality in those poor women, especially in developing countries, who die from postpartum hemorrhage. While there are other topical agents, such as bovine thrombin, recombinant human thrombin, and of course, hormonal therapy. We don't call them contraceptives in girls because a lot of parents would just get horrified if we say oral contraceptive. We call them hormonal therapy, and they raise the levels of coagulation factor. And then you have intrauterine devices which release levonorgestrel, and it's widely used both in this country and in other countries. So what about management of bleeding episodes and surgery? As you can see, it depends on the nature of the bleed, the duration, the age of the patient, et cetera, et cetera. And for minor surgeries, you can use DDAVP. And of course, we always use it with adjunctive therapy such as antifibrinolytics. So the minor surgeries may be elective or emergent, all the surgeries. And minor include like tooth extraction, synovectomy, endoscopy, circumcision, etc., etc. And similarly, there are minor bleeding episodes, such as, in many cases, nosebleeds. Sometimes it can be chronic and debilitating. But trauma, heavy menstrual bleeding can be minor in some patients. And the major bleeding are, of course, synovectomy, all the biopsies, line placement, etc. And by age, most children undergo adenotonsillectomy, circumcision, and dental work, whereas older age group, you have to worry about orthopedic surgery, gastrointestinal, and reproductive. The importance of this slide is the use of DDAVP in surgery. And you can see that in different procedures, whether it's dental, gynecologic surgery, etc., the duration of treatment can vary from 1 day to 7 days. And, sometimes you may have to reuse it. And an experience in children, again, it's mostly once or twice daily for a couple of days. Similarly, if you look at the surgery types and duration, for minor surgery, your requirement would be 1 to 5 days, whereas for major surgery, it can be anywhere from 7 to 14 days. So there is no set date. It depends on the age of the patient and the type of the surgery. And if it's very simple and uncomplicated, a single dose suffices. And if you see this, the dosage varies anywhere from 40 to 60 units per kg for major surgery to down to as much as 20 to 60 units per kg for spontaneous bleeding, and 50 units per kg, perhaps higher, for patients undergoing delivery and postpartum. And I think you have to remember, you target for hemostatic plasma level. I think that is the most important point of this particular slide. In cases of bleeding episode, once again, your loading dose is usually followed by a maintenance dose. And for minor surgery, clearly it is lesser number of amount or dose, but please, we dose usually to the closest vial. Can you give it continuously? Yes, there have been reports of continuous infusion of von Willebrand factor concentrate, but it's not reported very much. The efficacy, and if you look in the last column, you can see the efficacy is anywhere up to 90 to 100%. So it's very efficacious. Recombinant factor, von Willebrand factor, is the dose is again the same as 50 to 80 units. Since it doesn't contain factor 8, if you need factor 8, or if the factor 8 levels is low, you have to supplement it with giving extra doses of factor 8. And you can see if a dose of von Willebrand factor is given, you can omit the initial dose of factor 8 if it's given 12 hours before surgery. And Dr. Pavandi has shown the efficacy to be excellent to good in 15 surgeries, about 100%. Some of them were major and some of them were minor. And again, I think I'm not going to go over in detail, but the major thing is to at least keep a close contact with the surgeon and your colleagues to make sure that you offer optimal care. You can do DDAVP testing and use products to make sure that the patient doesn't bleed either during surgery or post-surgery, during delivery or post-delivery. I'm going to let Dr. Kadir address the gynecologic, and so I'm not going to do that, but just say a few words about prophylaxis. And I'm so glad that the new recommendations that are coming out from the joint World Federation, ASH, ISTH, NHF, is going to address this issue of prophylaxis. So briefly, prophylaxis is indicated in severe von Willebrand's disease who are non-responsive to DDAVP. And mostly the indications are recurrent epistaxis, heavy menstrual bleeding. And Dr. Ragni has a current ongoing trial looking at basically looking at tranexamic acid versus recombinant von Willebrand factor in preventing heavy menstrual bleeding. And I hope that is going to be very successful, so then we have some options for these patients. I think one of the common things that used it is used is in a bleeding and the gastrointestinal bleeding, which is a very, very difficult type because it's very common in types 2 and 3, and it's higher than in non-von Willebrand patients. And clearly, joint bleeding is also seen in mostly type 3 von Willebrand patients who need prophylaxis. So this was a study by Abshire, the von Willebrand disease prophylaxis network, and it had 59 subjects with type 3 accounting for 57%. The mean age of prophylaxis was 22. Those with epistaxis were lower, and the dose range, varied between 40 to 80, and it was very successful. You can see the bleed reduction, joint bleed were really reduced by almost 80% or 85%. And there was reduction in epistaxis, GI bleeding, and heavy menstrual bleeding. Only one patient did develop an inhibitor. The VPN study continued and showed that in adults, gastrointestinal bleeding was the main reason. In children, epistaxis was the main reason, and the median annualized bleeding rate was significantly reduced for epistaxis, GI, joint bleeding, and menorrhagia with prophylaxis. And the greatest decrease occurred in type 3 patients. So what happens when patients don't respond? So there was another study with dose escalation, and it showed that in 11 subjects, 7 out of the 10 had dose escalation, 6 had epistaxis, 3 gastrointestinal bleeding, and 2 joint bleeding. And the level change was based on bleeding site, PBAC score, or the pictorial blood assessment chart score for heavy menstrual bleeding, transfusion, and hospitalization. So it started out with 50 units per kg weekly, 50 units per kg 2 times, and 50 units per kg 3 times. The annualized bleeding rate with this type of a regimen decreased from 25 to 4. Very, very impressive. So this was a study by Dr. Pavandi comparing long-term prophylaxis. And clearly, if you look at it, on-demand therapy, if you look at, I think, last but one bullet point, on-demand therapy, the bleeding rates were 172 versus prophylaxis of 32. And again, epistaxis, joint bleed, and GI were the most common one. Just one slide just to show that you have to be cautious in older patients with von Willebrand disease, particularly not only with von Willebrand factor, but also with anticoagulants, antiplatelets, DDAVP, et cetera, et cetera. And we really need research and clinical trial in older patients to see what is the best type of treatment. So with this, I will pass the baton on to Dr. Kadir, who will address the next session.
Okay, thank you very much. And so I'm going to address issues and management of women with von Willebrand factor disease from the global perspective, actually focusing on some simple measures that could have a big impact on care and health of women with von Willebrand disease. So let's first look at what is the impact of von Willebrand disease on women, and especially on their reproductive health and well-being. So we know that from studies that women with von Willebrand disease have significant bleeding symptom, and this study in Italy showed that 63% of women with von Willebrand disease had severe bleeding symptom with a bleeding score more than 12. And if we look at the graph, you can see that every single bleeding symptom is higher in women with von Willebrand disease compared to women with other bleeding disorders. In addition to these general bleeding symptoms, women during their reproductive life are exposed to hemostatic challenge of menstruation, ovulation, of course, childbirth, and this leads to variety of gynecological bleeding, heavy menstrual bleeding, hemorrhagic ovarian cyst, and endometriosis, of course, as well as postpartum hemorrhage. But we know that heavy menstrual bleeding remains the most common bleeding symptom in von Willebrand disease, and all these studies have shown that about 3/4 of women with von Willebrand disease have a high menstrual score, the normal being 100. In the study here in our center, the mean score for the menstrual score was over 1,000 in women with severe von Willebrand disease before we treated them. And of course, that has a big impact because it's every month and it starts from menarche and goes beyond menopause. So when it comes to pregnancy, the main risk of bleeding is postpartum hemorrhage, or sometimes you have concealed bleeding in the form of perineal or pelvic hematomas. And again, these studies showed that women with von Willebrand disease have higher risk of postpartum hemorrhage. Not only that, the hemorrhage is usually more severe and needs more likely to need a blood transfusion. So these female-specific bleeding have significant impact on the quality of life of women, and this is a survey that we did yet last year through the European Hemophilia Consortium, and women with von Willebrand disease reported significant impact on their physical, romantic, social aspect of life, their activities, and most importantly, on their reproductive life. About 1 in 4 thought that having a von Willebrand disease impacted their reproductive decision to become pregnant or have more children, and a symptom that had the biggest impact was heavy menstrual bleeding. So, of course, these gynecological bleeding and obstetric problems we can manage, we can help, but first we need to identify and diagnose these women, and this can only be achieved by improving recognition and awareness of women bleeding issues. And I think we have done a lot, and we have had huge strides in achieving this goal since we started in 2005, when we started our women project at the Hemophilia Society in UK. We were one of very few societies with a women project. But now today, almost all societies and national members organization have either a working group for women or actually chaired by a woman. We have also managed to set up committees with all international medical societies specifically for women, working with the patient advocacy group to improve care of von Willebrand disease in women. And actually last year, we're very pleased that we ran a specific congress for women with bleeding disorders. And I think that was a big opportunity for working together, healthcare professionals and the patients, to improve diagnosis and care of women. This year, unfortunately, we had to cancel the meeting due to the pandemics, but we ran 2 nice webinars. So I think all these efforts that we made has made some difference. Of course, we have to continue working on this initiative, but if we can see the WFH global survey, the international survey, that this shows a 71% increase in the diagnosis of women with von Willebrand disease compared to 2007. So we have achieved something. I also wanted to share with you this survey that was performed by the von Willebrand Disease Working Party prior to the International Collaborative von Willebrand Disease guideline, to see the priorities from the point of view of stakeholders, which question to be addressed for the guideline. And I'm very pleased to show you that the management or treatment of women's bleeding issue score the highest, not only among patients, among women with von Willebrand disease, but men with von Willebrand disease, as well as healthcare professionals. So the next area where we can improve health of women with von Willebrand disease or other bleeding disorder globally is to act on the problems that are common, and we can apply simple measures with a big impact. And I can't think of any 2 examples more than tackling anemia and a postpartum hemorrhage. So this data, for the latest data from World Health Organization, shows that 30% of women of reproductive age and 42% of pregnant women have anemia globally. And if we look at the map of the world, you can see that in some countries, less resourced countries, developing countries, the prevalence of anemia reaches 80 to 100%. Majority are iron deficiency anemia in relation to menstrual bleeding, pregnancy, and childbirth. But of course, we all know that anemia has significant ramification on the mother and her baby and her quality of life. I can't go through all this impact of anemia on her and her baby, but looking at women with von Willebrand disease, having anemia make her less able to stand any bleeding, more likely to need blood and blood products, and has to have morbidity and mortality. The WHO initiative is to reduce anemia globally by year 2025 by 50% in women of reproductive age. But we clinicians have a role when we see any individual, any women with heavy menstrual bleeding or pregnant, we have to always prioritize diagnosis and management of iron deficiency and anemia, because the treatment is very simple with oral iron in majority, but of course IV iron if they are non-responsive or very severe bleeding. So now looking at postpartum hemorrhage, we all know that postpartum hemorrhage remains the leading cause for maternal mortality globally, especially in the low and middle income countries. And the majority of cases, the cause either preventable or the magnitude of the bleeding can be mitigated. And so to reduce the risk and the severity of postpartum hemorrhage, we have to understand what causes postpartum hemorrhage and also understand that the majority of postpartum hemorrhage occurs because of what we call uterine atony, which is when the uterus muscles does not contract after the childbirth. So during pregnancy, there is increase in the blood volume, and also there is a rapid increase in the cardiac output. By the end of pregnancy, a pregnant mother has a cardiac output of 7.5 liters per minute. And if the uterus is not contracted, the vessels that are large at the bed of the placenta is bleeding. There is no clotting factor. No matter how much clotting factor you give her can stop the bleeding. We need the uterus to contract. And if these vessels are wide open, she is potentially at risk of losing over a liter every minute and becoming a massive postpartum hemorrhage. So it is very important that we prevent or treat uterine atony, and studies everywhere have shown that active management of placental delivery and the use of uterotonics, i.e. medication that contract the uterus after birth, can reduce postpartum hemorrhage and decreases its severity. In the Western world, we use symptometrin or syntocinon, which are given parenterally, but misoprostol is a tablet that is not expensive and can be given orally, and the studies have shown that it can save mother's life when it's given in the rural areas by birth attendant. I actually, in my practice, I give misoprostol to every woman with a bleeding disorder after childbirth, in addition to symptometrin, to ensure sustained uterine contraction. Of course, in women with von Willebrand disease, we have to ensure adequate hemostasis. And as Roshni has mentioned, the therapeutic options include tranexamic acid, DGAVP, and factor concentrate. So tranexamic acid, it's a marvelous medication, especially for postpartum hemorrhage. And as Roshni said, it was designed for postpartum bleeding. And this big trial, women trial, which is international trial, including 21 countries, they looked at the tranexamic acid administration as soon as postpartum hemorrhage diagnosed compared to a placebo. And they demonstrated a significant reduction in maternal mortality in developing undeveloped countries of women due to postpartum hemorrhage, and reduce need for laparotomy or surgery to stop the bleeding. One of the important findings of this study was also that the sooner you give the tranexamic acid, the better. And if you give immediately after birth, it reduces death by 1/3. And that makes sense because the fibrinolysis, it is really initiated and enhanced immediately after childbirth. The study also was reassuring to show there were no difference in the adverse events between placebo and tranexamic acid, and specifically there was no risk of venous thromboembolism in the mother, and there was no thrombotic event in the baby in either group. So the last thing I want to address is we really want to provide a comprehensive care for a multidisciplinary approach to the management of gynecological bleeding in women. And that is important to have a good collaboration between a gynecologist and the Hemophilia Treatment Center, because most of the gynecological bleeding, abnormal uterine bleeding, is not caused by one pathology. And even in women with von Willebrand disease, it could be due to a gynecological condition. And that's why gynecological assessment is very important to rule out pathologies that are common, such as fibroid, polyp, and more importantly, the precancerous and cancerous condition, which increases with age. So multidisciplinary approach is very important. It's helped better diagnosis, provision of individualized treatment, plan for the patients, and gives them the confidence because they tackle all aspects of their problem, and they have better compliance, taking medicine, and better response. In this survey at the bottom of the slide, you can see in our center, we surveyed over 100 women who attend our joint multidisciplinary clinic, and over 90% of them were highly satisfied because they could manage all their health issues and concern in one visit. And also, providing a multidisciplinary approach would help us to individualize the care specifically to the women we are seeing, tackling the gynecological aspect with hormonal treatment, at the same time using hemostatic agents to tackle their bleeding disorder or coagulation defect. And that really helps to reduce the need for surgery, specifically hysterectomy. And we know that hysterectomy is a major surgery and has significant risk in women with von Willebrand disease with a higher risk of bleeding complication, need for blood transfusion. Now, even in the general gynecological practice, we now hardly use hysterectomy for heavy menstrual bleeding unless there are big pathologies such as large fibroids, endometriosis, and the rest, because we have a good long-term medical treatment that is achievable with levonorgestrone, which is a hormonal bearing intrauterine system, generally called Mirena IUS. And there are many studies that showed the efficacy of levonorgestrone containing intrauterine system comparable to hysterectomy in the sense of improving hemoglobin, improving quality of life. Here in women with von Willebrand disease in our center, we reviewed these women after 12 months, and all of them achieved a menstrual score below 100 with improvement in quality of life. And this intrauterine device is licensed for 5 years, so the woman can have it and not to have need any medication. Not only that, some data from China shows that it can sustain its efficacy up to 10 years, and that's very relevant with its use in the countries or areas with low health resources. When it comes to pregnancy, fortunately, women with von Willebrand disease do not have additional antenatal complication. So the main issue that we have to focus on is assessing her bleeding risk at childbirth and preventing that postpartum hemorrhage. And this could include monitoring her clotting factor during pregnancy, doing the DAVP response test, as mentioned in the previous talks, and having a multidisciplinary meeting with her to plan the treatment. So most of the women with von Willebrand disease, especially the mild and type 1, have increase in their clotting factors. And by the time of the childbirth, they have levels in the normal range. And for these women, tranexamic acid is sufficient hemostatic cover to prevent postpartum hemorrhage. So, for management of postpartum hemorrhage in the UK, the national guidelines suggest stratification of risk based on the severity and the type of von Willebrand disease, factor levels, and the mother's obstetric risk factors. And as I mentioned, for type 1 and mild, tranexamic acid is sufficient. Desmopressin can be used in those cases who are responsive with a moderate level of von Willebrand disease, and of course factor replacement therapy for type 2 and 3. And when we're giving the factor concentrate, there is no clear evidence what is the best level to achieve in these women, but certainly most people agree that we have to achieve a level of 100 and maintain the lowest level above 50 until the hemostasis is secured, usually about 3 to 5 days, depending on mode of delivery. And also we have to always give tranexamic acid as an adjuvant therapy, because that will further improve the hemostasis and reduces the need for factor concentrate. So I could conclude my talk by showing you that women with von Willebrand disease do suffer a significant bleeding complication, mainly heavy menstrual bleeding and postpartum hemorrhage, and they are the majority of women with bleeding disorders. And unfortunately, many of them still are diagnosed. And I think to work together and make effort to have better diagnosis, identify these women, and provide them better care. I'm sorry, my slides keep going backward, but with that, I want to thank you everybody for listening.
Two, one.
All right. I'm sorry that Dr. Ragni lost the connection, so I'm going to be moderating. We have probably 5 to 10 minutes for tackling some of the questions. First question is that thank you for the speakers, and we are very
Your
pleased that the
expectation.
session was up to your expectation. There's a question here. For me, as I do, women with von Willebrand disease have more frequent miscarriage than women without. Well, I mean, there is no clear data, but I think, in my opinion and my experience managing women with von Willebrand disease, is certainly in women with type 1 and mild, there is no difference from the general population. In type 3 and severe von Willebrand disease, because the numbers are so small, it is very difficult. And I have had colleagues, and even in our center, we managed one lady who had recurrent miscarriage, but there were no other cause, and we gave her prophylaxis, and she continued pregnancy. So it's not evidence-based, but on individual basis, you can decide whether she's about to consultate to maintain pregnancy. There is a question: what is the risk of developing inhibitor to von Willebrand factor? Is this higher with recombinant factor? I will ask Dr. Kulkarni to answer this question, please.
Yeah. So there is always a risk, but I haven't seen any reports of neutralizing inhibitors, so antibodies can be neutralizing and non-neutralizing. I think during the clinical trial, there may have been one case of a non-neutralizing, but I think as far as I know, I am not aware of inhibitor developing during the clinical trials. And I think Everybody knows that patients who have type 3 von Willebrand's disease from frequent infusions of von Willebrand factor can develop inhibitor. So one should be aware of it. In the inhibitor, especially in the case described, was against factor 8. So we should be vigilant. And if the person is bleeding or the hemorrhage is not stopping, then you have to do Bethesda assays to determine if the patient has an inhibitor.
Thank you, Professor Kulkarni. There's another question I would direct to you as well. A comment on recombinant von Willebrand factor that contains possibly traces of factor 8.
I'm sorry, I didn't get that.
So a comment on recombinant von Willebrand factor contains traces of factor 8. I think probably we lost Roshni from the connection. Unfortunately, I won't be able to answer this question as a gynecologist.
If I understood the question from the author.
We need only recombinant von Willebrand factor because the patients with type 2A or type 2B have a baseline level of factor VIII pretty normal. Is it clear, my answer?
Yeah, thank you very much, Professor Federici. So I think we are coming to end of our session, and I can't see any more questions coming up. I would like to thank you very much for your participation in this session, and also thank the speakers for their excellent contribution. And I would like to say goodbye and have a very good weekend.
Thank you. Bye.